Good evening, good evening, good evening, good evening, everyone. Thank you so much for joining us again for what promises to be an amazing, amazing webinar. We apologize for the late start today. However, we thank you so much for taking the time out on Champs Thursday. Woo, go high schoolers um, to join us for this wonderful webinar. It is a two-part series, this webinar, very unique and different. The team has tried to put together something that accommodates everyone. And so we thank you again for joining. And it's my pleasure to hand over to our moderator for this evening's sessions, the wonderful Dr. Aileen Standard Wilson. Over to you.
Thank you very much, Mr. Heron. And thank you all for joining us. Welcome to the Caribbean College of Family Physicians Jamaica Chapter Neurology Webinar Session 1. The theme being varying phases of neurological disorders in primary health care. Very happy that you are all able to join us. Just to start the session, we're just going to start with a prayer, which I think, Mr. Heron, you have queued up for us.
Heavenly Father, all-knowing Lord God, we thank you for this opportunity to gather together in your presence for this Neurology Symposium by the Caribbean College of Family Physicians. Come amidst us, we pray, as we start the proceedings, and ask your blessings on each person, that you would guide our minds and hearts as we learn during these scheduled meetings. Help us to seek your truth, to grow in knowledge and wisdom, and to put into practice the things we learn as we discuss the various aspects of neurological disorders that affect our patients. May the insights gained be used for the betterment of ourselves and those entrusted to our care. We humbly ask for your guidance, understanding, and help to comprehend the concepts imparted by our esteemed presenters, to be able to apply them in a meaningful way. We pray for the speedy and efficient resolution of any technical issues that may arise, to allow for the smooth transition of the meeting. Abundantly bless our sponsors, the moderators, the speakers, the audiovisual team, and our administrator as they perform their various roles to ensure another successful and excellent symposium. Pour your blessings on all participants and hosts as they give of their time to join on this platform for the benefit of all in their care. All these we ask through Jesus Christ and the Holy Spirit. Amen.
Amen. And thank you very much for that. Moving right along, I'm going to invite Dr. Senin Onanuju, who is the president of the Caribbean College of Family Physicians Jamaica chapter, to bring greetings and welcome to all who are present. Dr. Onanuju.
Good evening, everyone, to all our participants, presenters, moderator, administrative team, IT and technical support staff, and our sponsors. A pleasant good evening to all. I am Dr. Seni Ononoju, current president and chair of the Caribbean College of Family Physicians Jamaican chapter. It is my distinct pleasure and honor to be here this evening as we are assembled virtually for part one of what promises to be an educational and enlightening presentation. To give some context and some insight as to the scope of the problem and its relevance to this evening's discussion and beyond, let us look at a few things that we're going to talk about. Multiple sclerosis, it's an autoimmune disorder which affects function in cognitive, emotional, motor, sensory, or visual areas, and occurs as a result of a person's immune system attacking their brain and spinal cord. According to the World Health Organization, it is estimated that over 1.8 million people have multiple sclerosis worldwide. People of all ages can be affected. It is more common in young adults and more so in females than in males. Multiple sclerosis can improve or stabilize by being treated with medicines early in the course of the disease, and treatments will be different for each person depending on the severity of the disease and symptoms. Alzheimer's disease is the most common type of dementia, and it is a progressive disease. The number of people living with the disease doubles every 5 years beyond age 65. According to the Center of Disease Control, CDC, in 2020, as many as 5.8 million Americans were living with Alzheimer's disease, and this number is projected to nearly triple to 14 million people by 2060. Brain tumor and brain cancers were estimated to be the 10th leading cause of death in 2023 for both males and females in all age groups. Survival rates for adults and pediatric patients with brain tumors have not changed significantly over the past 45 years, despite major improvements made in the treatment of other cancers. From the above statistic, we can see that these disorders take a toll on the health burden of any country, which can be improved with early diagnosis and appropriate management, especially at the primary healthcare level. As such, we have in our midst a lineup of 3 exceptional speakers who will expound on these during the course of the evening. Doctors Francine Gale, consultant neurologist, Esther Govaya, research psychologist, and Georgia Penkol, consultant neurosurgeon. Doctors Gale, Govaya, and Penkol, we welcome you wholeheartedly. I wish to seize the opportunity to acknowledge the members of the college who continue to attend and participate during these events, and all other allied healthcare workers for their attendance and participation. Thank you, and God's richest blessings.
Thank you very much, Dr. Ananuju, for setting the stage, giving the background as to the importance of the topics that we're going to be addressing this evening. I would like to introduce to you the first speaker, who is Dr. Francine Gale. She is a University of the West Indies medical graduate, having acquired her MBBS with honors and her Doctor of Medicine DM in Internal Medicine from the UWI. She is also a double board certified neurologist and stroke neurologist, having received her specialist certificate in neurology from the Federation of the Royal College of Physicians and Surgeons of the United Kingdom, and her stroke neurology expert designation from the Fellow of the Canadian Stroke Consortium. Dr. Gale is also a fellowship-trained person in stroke research and medical education research, with a concentration in upskilling generalists in the practice of neurology in underserved areas using virtual learning platforms. So you can see she is well qualified to present to us today by this method. Dr. Gale is a tele-neurology expert. She is the medical director of Everbrook Limited, a private healthcare company, and is the new chief medical officer of Andrews Memorial Hospital in Kingston, Jamaica. She is also currently an adjunct assistant professor of neurology at Johns Hopkins School of Medicine. It gives me great pleasure to welcome Dr. Gale and look forward with her sharing with us on the topic multiple sclerosis, what every family physician should know. Dr. Gale, over to you.
Thank you so much, everyone. I'm truly excited to be a part of this symposium. I see over 100 participants on the line, and we're gonna have a great time. In fact, I feel like I'm about to talk to myself because as a stroke neurologist, I have not had to give a talk on multiple sclerosis in probably about maybe 8 to 10 years. So let's begin. I'm going to share my screen. All right, so multiple sclerosis, what every family physician should know. I'm going to start by asking two questions. The first is, what do you think is the average length of time from the onset of the initial symptom to the referral to the neurologist in clinical practice in someone who invariably turns out to have multiple sclerosis? Do you think it's less than 6 months, 6 months to a year, 1 to 2 years, 2 to 5 years, greater than 5 years, or you are unsure? All right, I'm going to give you 2 more seconds. Just hold your answer. Question 2. Which symptom is commonly seen in multiple sclerosis but universally ignored? Blurred vision, itching skin, tightness of the torso, fatigue, numbness in the limbs or feet. 3 more seconds. I see some comments going into the chat. We will
for the
see.
first one, most persons said E. For the
Unsure.
first pre-test question, they were unsure. We also saw some over 5 years, 2 to 5 years, 6 months to a year, so it was all over the place. So it means that your talk is definitely timely to ensure we narrow that down. And for this one, I'm seeing blurred vision, fatigue, and blurred vision again, fatigue. So the 2 main ones are blurred vision and fatigue.
All right. Well, let's proceed, shall we?
Sure.
Learning objectives. So we are going to just briefly touch on the neurologic burden of disease, which we had a synopsis earlier. We're going to do a very brief overview of MS. And instead, we're going to hone in with some focus on the symptom-based approach to multiple sclerosis. We're going to briefly discuss some screening tools and the question of what do you order? And then we're going to comment on monitoring and surveillance. So if you're ever asked about the global burden of neurologic disorders, this is the seminal article that you should quote, Lancet Neurology, back in 2019. And it clearly defined the top 10 neurologic disorders that have the burden pretty much centered in low to middle income countries in about 80% of all cases. You will see that multiple sclerosis is actually there. It's a turquoise hue, and it spans the early 20s. It's a faint line, but it's there, and it goes all the way up into the mid to late 60s. You will also note that when we drill down on disability-adjusted life years and deaths, multiple sclerosis accounts for 0.5% worldwide of disability-adjusted life years, and it's among the bunch, 0.2% as the cause of death. And this may sound small because you're thinking of the large numbers, 67% that stroke and the 20% that Alzheimer's and other dementias may carry. But when you factor in that multiple sclerosis sits in the young, typically female population, that burden can oftentimes be significant for the home. So simply put, multiple sclerosis is an autoimmune process. There are many postulates that have been bantered about, and we have settled that it is a multifactorial issue and that there is a genetic predisposition. Environmental factors have been commented on, whether you're north of the equator compared with south, the role of vitamin D and vitamin B12 deficiency, viruses such as Epstein-Barr virus and herpes virus 6 have all been evaluated and thought to be causative. And now smoking has entered the camp as a more or less definitive causation when it comes to multiple sclerosis, particularly among the young. And we now know that all of these environmental factors in a susceptible host results in a triggered cascade, which leads to autoimmune acts against the myelin, which then results in a loss of this covering, a reduction in saltatory conduction, and therefore, in effect, slowed pretty much a neuron that is, we like to say, dead in the water. And this results in quite a widespread area of dysfunction within the central nervous system. We now understand the T cell cell types as well as the B cell types, and now all of the interleukins that are involved in this autoimmune cascade. All of these have been well documented. And so as we've gotten more and more information, or therapy has become more and more targeted. And we'll discuss that as we go along. One of the areas of controversy for family physicians rests with the whole concept of vitamin D deficiency. There was this hope that perhaps vitamin D deficiency in particular could decrease significantly the prevalence of multiple sclerosis. And this led to a significant increase in uncontrolled testing of vitamin D levels, even among individuals who were considered to be low risk. And so we now know, based on the American Association of Family Physician guideline, that appropriate indications are still to be kept for vitamin D testing. Yes, those individuals with evidence of metabolic bone diseases, malabsorption, renal disease, and liver disease. And yes, we do know that vitamin D has a significant anti-inflammatory effect. And so all our patients, whether younger than 70 or older than 70, should be having the required amounts of daily intake. And you will see there are 600 international units for those 70 or younger, and 800 international units for those 70 and older. We know that for those with documented inflammatory or autoimmune processes, that figure can be as high as 10,000, even 5,000 international units per day. But it should not be a blanket statement that these super normal doses be prescribed in an attempt to prevent the onset of an autoimmune process. The other caution rests with vitamin B12, which of course we know is a significant vitamin for the health of the nerves. We have noticed that there is oftentimes a discrepancy between lab values, the ranges of the lab values, versus the ranges where we see clinically evident neurologic diseases. And what we now know is that typically levels of vitamin B12 above 400 typically have no evidence of a deficiency. But you will find that when the patients are sent to the lab range says 150 all the way up to 900 as being within acceptable limits. And we now know that if you have concerns, symptoms, numbness in the hands, burning, tingling, and the value is less than 399, that you should obtain additional tests, for example, methylmalonic acid. So don't be fooled by the lab range as opposed to what is clinically happening in your patient. We know the typical subtypes of multiple sclerosis, whether it is relapsing remitting, which is the commonest types, where the patient will give you clearly defined, visible deficits that are usually involving visual loss or impairment, motor weakness or incoordination, or a distinct loss of sensation, which can be hemisensory, monosensory, or sensory level. Those are the classic descriptors that patients typically will describe when they have visible symptoms of multiple sclerosis. And I'm stressing that because it makes a difference to you what your patients may voice versus what you may have to elicit from them. And so the majority of the relapsing remitting paradigm speaks to the visible symptoms of multiple sclerosis. We also have primary progressive, which is a steady increase in disability without discrete attacks. And then secondary progressive MS, which is initially relapsing remitting, which unfortunately then begins to accumulate in a secondary progressive manner. And then you have progressive remitting, where even though you will have superimposed relapses, the overall pattern of the graph is a steady increase in disability over time. And so the average duration between the onset of symptoms of visible multiple sclerosis to the actual diagnosis is actually 2 to 5 years. What will alarm you is the concept of the invisible symptoms of multiple sclerosis, and those may actually be delayed for more than 10 years, and in fact may actually be more disabling in some instances than some of the typical visible symptoms, and I will explain further. So this article, we take a little sip, is excellent. I would advise every family physician to read it. Please take note of the reference. It is a comprehensive approach to the management of multiple sclerosis, and it addresses invisible symptoms. So you may ask, what are these invisible symptoms? The first thing I would want to say before we say what these invisible symptoms are is to recognize that multiple sclerosis is an autoimmune disease. Think of the paradigm that you have for your other autoimmune disease, or the paradigm that you have for your patients who are living with autoimmune diseases. And that will create a mind shift in you, a perspective shift in you for multiple sclerosis. Typically, I find that in physicians, whether family physicians or general practitioners, multiple sclerosis is on a branch by itself, as opposed to thinking about it as an autoimmune process. And so let's look at some of these invisible symptoms, because they are typically the systemic impact of this chronic autoimmune process that is literally having a slow, debilitating, quite exhausting, and oftentimes overwhelming impact on your patient. A lot of family physicians have a discomfort for neurologic disorders, and whether you realize it, that discomfort that you have gets transferred or gets felt by your patient. And so I applaud the college for actually having events like these, because we can talk about these nuances and help each other to figure out how we can support our patients. So the invisible symptoms: fatigue. Fatigue is at the top of the list. And I want you to take the tips that I'm providing you as it relates to fatigue and use it in literally every single diagnosis that you make for the rest of your life. Individuals with multiple sclerosis will have fatigue just by virtue of the autoimmune process. They will also have fatigue by virtue of the pain and spasticity that they have, which disrupt their sleep. Additionally, these individuals will also have mobility issues. And so imagine being in pain and having difficulty moving into a more comfortable position, and having to be in pain and stuck. So you're in pain, decreased mobility, and unable to turn in bed. Mood changes. We have to be able to give our patients hope that despite having an autoimmune process, that we are here to support them through not only the physical, the visible physical changes, but through the psychological, the mental, and what's next door, the cognitive changes of this condition. Physical, as I said, quite visible, but there is also emotional pain, because oftentimes, especially as it relates to women, but also men, there is a loss of the hopes and the plans and the aspirations that they may have had when they have to come to terms with the diagnosis of a chronic illness. Bladder and bowel issues. Be mindful of a young individual turning up, whether male or female, turning up with frequency, hesitancy, post-terminal dribbling, and you have examined them. Female, there's no fibroid, you've sent them for an ultrasound, there's nothing that's pressing on their bladder. For the male, their rectal exam didn't show that they had an enlarged prostate, you've sent them for an ultrasound, there's nothing. This could literally be the hint that there is a demyelinating process that is going on. Sexual dysfunction, whether a loss of libido, failure to orgasm, because remember, neurologic issue, all of those are involved in the invisible symptoms of multiple sclerosis. And I know as family physicians, and sometimes even as neurologists, we hone in on the optic neuritis as the end all and be all of the presentation of multiple sclerosis. But blurred vision, even without a history of migraine, and I know you can have auras without headache, but pair that with a loss of color saturation that may be very subtle, even without eye pain. Just be very mindful of teasing out what that blurred vision is like and whether they may have subtle loss in the quadrants in their visual fields. And so having a very low threshold for sending them to the ophthalmologist to have formal visual field testing done. So I have put up this list on the right that shows a number of scales that you can become familiar with. And oftentimes our patients are in our offices waiting on our appointments. If you have a well-trained receptionist or you have a nurse in your office who can just touch base to see the reason why the client or the patient is coming in. And if they're having a complaint of fatigue, you can pull out your little fatigue assessment tool and have the nurse request that they administer the tool. By the time they come in to see you, you have a talking point as to how severe the symptoms are. Likewise, with a depression screen, those are the tools that you can use. And in fact, at each appointment, in someone who has not been diagnosed with multiple sclerosis yet, but even in a client with whom you have a suspicion, these are tools that can be used for assessment. And in someone who has been diagnosed with multiple sclerosis, these are tools that can be used to monitor. And they are the means by which you can then refer your patients to get the multidisciplinary care that they need. So remember, your patient as a whole requires the biopsychosocial care. And so open communication, stigma mitigation, having the discussion about what they would like, what specialties they would desire to have involved in their care, that is a part of shared decision-making, being very familiar with the validated screening tools, as I have listed there, and just having the knowledge and the understanding of the patient's perspective so that you can actually provide patient-centered dialogue. I know that, we are grown in the culture that the physician takes the center stage in a lot of what we do, but we're actually here for the patient. So what do we order and when do we order? So if you see a patient and that patient, let's choose bladder issues, frequency, hesitancy, post-terminal dribbling in a young woman, you have done all of the gynecological, you've eliminated a urinary tract infection, you do a focused exam, right? Because now that you have MS or a demyelinating disorder not the back, the side of your mind, you're gonna start checking all the other areas that will allow you to see if there is evidence, right? So you're gonna look at the back of the eyes. You're gonna do your swinging light test to see if they have a relative afferent pupillary response. You're gonna look at the back of the eyes to see if they have any disc pallor. You're also gonna do subtle things like your drift, okay? Yes, your patella hammer, very useful to see if there is any asymmetry in the reflexes. But one of the things that I found that allows you to pick up subtleties is asking to do rapid distal movements, right? Even asking them to pretend to screw in a light bulb, which allows you to see if there is subtle spasticity, because this has to be equal to this, right? I'm left-handed, and so my left hand is gonna be a little bit more fluid than the right, but it should not be significantly different. Some tricks that I've learned, yes, the reflexes for the lower limbs, and you're looking to see if they're hyper-reflexic, if their Babinskis are up, right? If they have clonus, but you're also looking for subtle things like, can they tandem walk? Are they able to walk on their tippy toes or on their heels? They should be able to do that symmetrically. And even though you're in an office setting, don't be fooled by missing a subtle sensory level. When I was in training, the sensory level can be very, very subtle to the extent that the patient only says, yes, I'm having some numbness and tingling in my legs, but do your due diligence to continue to evaluate not just the leg and the thigh, but to go up onto the trunk, because then that will allow you to delineate the level and therefore know, do I need a cervical or do I need a cervical and a thoracic? And it's expensive, I know. So if the individual is complaining of cognitive issues, you know you're gonna hone in on the MRI brain with or without gadolinium. I know our radiologists in Jamaica would typically guide whether or not the contrast is given. If the patient is having eye symptoms and you invite the ophthalmologist to be a part of the dialogue, they would typically request to have the optic tract to be investigated inclusive of gadolinium. Now, if you're having a full-blown hemisensory, then you may have to do your cervical and your thoracic, especially if you're having patchy involvement of the sensory symptoms all the way down onto your trunk. I've also had the distinct pleasure of seeing a number of MRI reports, and this is very important for the family physician. The question of small vessel disease, and could I ask my timekeeper how many minutes do I have left?
You have about 15 minutes left.
Okay,
Yes.
thank you. So the whole question of reports that state small vessel disease versus inflammatory demyelination. I'm gonna go down that road a little bit. All right, so we know that the classic demyelinating lesions that we are taught textbook are the periventricular T2 hyperintense with perpendicular finger-like projections that are classically called Dawson's fingers. You may also get juxtacortical T2 hyperintensities, or you may get deep T2 hyperintensities. You can also have, it's not really showing as well as I would like, but take my word for it that there is a loss of volume in this area of the brain, in the subcortex. So classically, periventricular T2 hyperintensities with perpendicular finger-like projections known as Dawson's fingers. That is a classic MRI description that you will see that suggests, that is in keeping, sorry, with multiple sclerosis. Then you would get the enhancement with gadolinium if it is an acute lesion, or you would get no enhancement with gadolinium if it is a chronic lesion. And sometimes the radiologist will say a punched out lesion, or they will literally say that there is a hole, H-O-L-E, in the corpus callosum. These are some of the descriptors that you will see when you do report, when you send a patient for the MRI. Similarly, in the spinal cord, and I'm going to touch a little bit on what you might hear when it comes to the spinal cord. It gets a little complicated when you have a young female and you don't have the classic descriptor. And what you may get is a few scattered T2 hyperintensities, and the radiologist is unable to make the distinction between small vessel disease and inflammatory demyelination. Those patients should be referred to have that question answered by the neurologist. And here is the reason why. We now know that there is no small vessel disease that is innocuous. Small vessel disease is actually a precursor and a marker of a stroke risk down the road. It's also a marker of vascular dementia and mild cognitive impairment. And I won't encroach on anybody else's presentation. So you're gonna do a lot of CAT scans for other reasons, and you're gonna get reports that will say small vessel disease. Small vessel disease can be caused by many chronic illnesses. And as I said, it's a blaring sign that says, Doc, my chronic medical illnesses, whether my diabetes, my hypertension, my dyslipidemia, those are not at the targets that they need to be, and this patient is at risk of having a stroke in the years to come. A young girl with migraine, a young man with migraine is a conundrum, because migraine can present with little T2 hyperintensities. And guess what? Migraine can also present with features that are similar to some of the invisible symptoms of multiple sclerosis. And so you have to tease out that pattern of being within 30 minutes of the headache, whether there is a linkage with a menstrual cycle or being triggered by food, right? Whether the visual symptoms that the individual is having is pixelated and it's moving across the visual field. Very precise, because those distinctions count, all right? Remember also with multiple sclerosis does not typically involve multiple segments of the spinal cord, unlike neuromyelitis optica, where 3 or more contiguous segments and the majority of the cross section of the vertebral level is involved in neuromyelitis optica, as opposed to multiple sclerosis. And that is why it requires your sensitivity, because in one of the previous tests, I asked tightness in the torso. And I have had a multiple sclerosis patient, and that was her complaint. Doc, I have tightness in the torso. It wasn't her bra, right? It wasn't close-fitting clothes. She actually had involvement of her T6 spinal level with a demyelinating plaque that had involved just about a third of the cross-section of that level. And what she was having was spasticity in the thoracic muscles. So don't be fooled, all right? And I've had a patient, and this is very unfortunate. She actually presented to me about 15 years after having cognitive complaints, brain fog, difficulty with word finding, just not being able to function at the level that she was able to at her job. And she was a high functioning lawyer and had been expressing to her physician that something was just off. And she was being told that she was just tired, she needed to take a vacation, no brain imaging was done. By the time she decided to take matters into her own hands, her brain looked like this. She had atrophy and T2 hyperintensities and Dawson fingers. Monitoring and surveillance will invariably land in your lap, right? Because the MS patients will go to the neurologist, they will get placed on disease-modifying agents, but they will continue to come and see you. And so you will now be required to say, is the medication working? And so at every visit of this patient, even if it is for a cough or a cold, you will need to do an inventory of neurologic symptoms, those are the visible ones, as well as the invisible ones, because you're trying to elicit whether or not there are any clinical relapses or exacerbations. And you're trying to make sure that there is no change in the level of disability of your patient. There is no change in the neurologic exam. Because if you find that, you need to relate to the patient's neurologist, you need to localize where the issue is, and you need to order follow-up imaging and request that the patient goes back urgently. And I know you're gonna say the wait time, but this is your responsibility still to advocate, to get the neurologist attention, to say, hey, please prioritize this patient. I think that they are in a flare. The other thing that you should know too is that the aim of the disease-modifying agents is for no evidence of disease activity. We now go all the way up to stem cell transplant in our patients with multiple sclerosis in order to ensure that the disease is actually in remission. And so no longer do we accept any exacerbations once we have started our disease-modifying treatment. And because we now know the disease burden, especially as it relates to the invisible symptoms, and cognition is at the forefront, second only to fatigue as it relates to the invisible ones. And unfortunately, brain atrophy, I've seen far too many brain atrophy because of the missed issues with cognition. Before I get to the post-test, there was one other thing I wanted to say. So So when you also do your evaluations, when your patient is coming to you for regular checkups, blood work is also your responsibility to make sure that your patients have not developed cytopenias. And typically, when they are getting the disease-modifying agents, each drug has its own schedule. And so the neurologist has the responsibility of sending to you the required follow-up schedule for the CBC, the LFTs, and sometimes even muscle enzymes, depending on the drugs that are being used. Additionally, leading up to the commencement of disease-modifying agents, you are also responsible for screening for JC viruses. And remember, guys, adults need to have their vaccine history kept up to date. Because before we can commence any disease-modifying agent, we need to ensure that all of the live attenuated vaccines have already been given, or else they won't be able to have them thereafter. All right, and so let's quickly look at what we asked before. What is the average length of time from the onset of initial symptom to referral to the neurologist in clinical practice for visible symptoms? The answer is D, 2 to 5 years. But unfortunately, for the invisible symptoms, oftentimes it is greater than 5 years, but not after this talk. We're all going to be doing our neuropsychiatric evaluations and our depression screens on our patients at every visit. And which symptom is commonly seen in MS but universally ignored? It's fatigue. The commonest underrated and explored symptom among family physicians, general practitioners, and specialists across the board. Thank you so much for having me, and I hope I kept within my 40 minutes. It's been wonderful.
Thank you ever so much, Dr. Gale. And yes, you did keep within your 40 minutes, and you did share a wealth of information with us that is especially relevant to us as family physicians. There are a few questions, but as I mentioned earlier, we're going to have just one question and answer session. So I'd ask everyone, if you have any questions for Dr. Gale, just put it in the question and answer link that is below. And when we come to that section, we will deal with all the questions. So thanks ever so much, Dr. Gale, for a very enlightening presentation. We're going to move on. We do have some sponsors, but we're not having any, they're not presenting today, but you will have seen them acknowledged, and they will be acknowledged again later. So we're going to move on to our second presentation, which is by Dr. Ishkar Bovaya, who, as Dr. Ananusha mentioned, is a research psychologist. She is a global leader in brain health and dementia care, whose expertise has been recognized with her nomination to the World Dementia Council. She is the founder and CEO of the UK incorporated startup Amaji Health Limited, which co-develops with partners in emerging markets, data-driven and tech-enabled solutions for brain health and dementia care. Currently, she is a senior consultant with the WHO's Brain Health Unit, coordinating initiatives around the world for the implementation of the WHO's Dementia Research Blueprint. As an award-winning social scientist and highly experienced senior academic, leading or co-leading grants totaling nearly $1 million, and those would be US dollars, I'm sure, not Jamaican dollars, Dr. Kovaya has held posts with the Caribbean Institute for Health Research at the University of the West Indies here at Mona, the University College London, the London School of Economics and Political Science, and the University of Michigan. She is the Vice President of the Caribbean Alliance of National Psychological Associations and a member of the Clinical Management Committee of the Bellevue Hospital in Jamaica. A recognized leader in Caribbean health and care networks, Dr. Kavaya centers meaningful partnerships, infrastructure development, and capacity building for sustainable health and care research, policy, practice, and innovation for underserved and underrepresented communities worldwide. So she comes with a vast experience, and she is going to share with us today on elements of Alzheimer's disease. So Dr. Kavaya, I welcome you, and I will by a note in the chat indicate when you have 15 and 5 minutes remaining. Thanks very much, and please go ahead.
Thank you so much, Dr. Standard Golden. It's a pleasure to be with you again. The Caribbean College of Family Physicians has been an unbelievable partner and collaborator in so much of the work that we've been doing in this space in Jamaica. So I'm thrilled to be partnering again and working with CCFPG to deliver this. So today we're going to be speaking about Alzheimer's disease, and we'll be talking about how that looks in Jamaica in particular, and some of the challenges and the opportunities that we have in terms of detection, diagnosis, and management. So to set a context, first of all, it's really important to understand that every 3 seconds, somebody in the world develops dementia. This does not mean that somebody is diagnosed with dementia or Alzheimer's disease or any other related type of dementia. It just means that we know that people are actually developing dementia every 3 seconds. And what is particularly concerning about this is that a number of people, including health and allied care practitioners, still believe that dementia is a normal part of aging. This is something that we do need to pay special attention to, particularly when patients come to us, when clients come to us, when they come to us after retirement, when they come to us when they're menopausal, because these are some of the ways that we dismiss concerns that they may have. And it's really important to understand that this is something that is happening in abundance in our health and care systems. As you may know, there are a number of pathways to dementia. And Alzheimer's disease is one of these pathways to dementia. It is the most frequent pathway, the most prevalent pathway, but there are others of which you are quite likely well aware. Vascular causes, as well as Lewy bodies and frontotemporal dementia are some of the others. What we know from research, particularly over the past few decades, is that what presents as dementia typically has at least a 20-year precursor period. And that may arise with and be demonstrated with moderate types of symptomologies. And even before those moderate symptomologies start to present, there's a stage of mild cognitive impairment. And there's also a silent stage where there is development and deterioration in terms of some of the brain's functioning and related organs. And that deterioration in functioning is not really visible either to the naked eye or even on some of the traditionally used investigations. And we'll spend some time today talking a bit about alternative types of investigations and some of the new developments that are on the market now. For some context, through work that our team has conducted, with the Strengthening Responses to Dementia in Developing Countries project, which was a Global Challenges Research Fund grant that was given to London School of Economics, and for which there were 6 other countries, middle-income countries, participating, and Jamaica was the only Caribbean country. What we understood from doing that body of work, which lasted over 4 to 5 years, was that we have a high proportion of our population that is affected by Alzheimer's disease and related dementias. In fact, over 13% of persons who are 60 and older are quite likely affected by Alzheimer's disease or related dementia. This pooled prevalence that we saw from looking at the studies that were conducted by Mona Aging and Wellness Center and relating that work to other studies that maintained specific diagnostic criteria in other countries of the STRIDE project. What we understood from that is that Jamaica's pooled prevalence is actually 9% approximately. This has a massive cost in terms of the economy, and particularly in terms of what it means for the progression of these individuals, because the vast majority of the Jamaican population does not have insurance, as you may know. Furthermore, there is no subsidization for dementia medication. And as you'll see in some of the feedback that we've gotten from some of our participants in our work, they found that there were unaffordable and inaccessible services, and quite much to our expectation, even the cost of a regular doctor's visit is typically prohibitive to persons who are in these situations. The drugs or the medications are also very expensive, and so patients can't afford them. And then the experiences that they tend to be having in the public and private healthcare services does not really lead them to want to engage with those services. And that's something really important for us to keep in mind as health and allied practitioners, because what we see from and heard repeatedly from our participants in this work was that they did not feel that they were treated with respect, and they did not feel like the person for whom they were caring was treated with respect. And it's really important to think about that and the additional burden and frustration that it puts on persons who are already in pressured situations. In addition, we heard a lot from our participants that they felt that the doctors really use very scientific names and don't speak to them in ways that they will really understand what is going on. And so it's really important to check in with your patients, check in with your clients to find out if they're understanding what exactly it is you're saying to them. And in terms of breaking down for them not just what they're presenting with, but if you are prescribing medication, if you are recommending that they get specific investigations done, that you're very clear about what those are. And we'll speak shortly about what some of the typical types of investigations ought to be. And again, really important to note that doctors do need to have and demonstrate empathy. As many of us are aging as well ourselves, and we encounter experiences with health systems, we become even more empathetic about what our patients might be experiencing. And so that's something that's important to think about in terms of the work that we can do as health and allied practitioners. So let's talk a little bit about diagnosis. So diagnosis of Alzheimer's disease and related dementias includes multiple steps. And we've traditionally understood that a definitive diagnosis could not happen until autopsy. There has been a progression and advancements over the past decades that's led to development of a specific type of definition of Alzheimer's disease, moving to a more clinical and biological definition. And so to gather the information that we need to reach that diagnosis involves multiple steps. We must take a detailed medical history. We must rule out other causes or contributing factors. We have to perform cognitive screening. We have to conduct blood tests for reversible causes of cognitive impairment. We also need to use neuroimaging, and this is particularly in cases when the onset of the cognitive impairment is presenting in somebody who is younger than 65 years old, when the symptoms begin pretty suddenly or progress very rapidly, and when there is evidence of any type of neurological deficits, when as well there is a recent history of a fall or a head trauma, and when the clinical picture suggests normal pressure hydrocephalus. In addition to those steps, it's also important to conduct neuropsychological assessments, and those neuropsychological assessments can help to differentiate different types of dementia in atypical cases. And they're very useful as well when the results of screeners and other investigations might be confounded by high education, because the neuropsych assessments, as we'll see from the list of some of the typical ones that are used, are quite extensive, and the reports that you can get can really specify domains of cognitive functioning, brain functioning that might be impaired. So breaking down each of those steps further. Medical history. This is a history that we need to gather from both the patient and from the care network member. In our work, for example, with interviewing practitioners, doctors, with the Davos Alzheimer's Collaborative project, and we'll talk a little bit about that project shortly. In our work, we heard a lot from doctors, from persons like yourself, that what they tended to find presenting in their practice when a patient would come would be things like disorientation, forgetfulness, and they would hear a lot more conclusive types of feedback from family members. So it's really important when you're thinking that there might be a potential cognitive impairment issue, that it's not just the patient, him or herself, that you're seeing, that it's also somebody from their care network. This may be a family member, or it might even be a neighbor in some cases. It's important as well to assess their levels of impairment in terms of their social or their occupational functioning. And there are standard measures for activities of daily living or instrumental activities of daily living that can be used for this assessment. Then assessing functional status, for example, what is their gait like? Have they been having frequent falls? Do you notice any tremors? Do you notice any rigidity? And again, try to get, because when the patient shows up to see you, you might not actually be seeing those presenting symptoms. So it's important to get a sense of recent history and any particular manifestations of those types of issues. And then assessing psychological status, emotional status, and behaviors. So depression, anxiety, agitation, hallucinations, delusion, any type of disinhibition that might be presenting. And disinhibition is typical, particularly with frontotemporal types of dementias and mixed dementias, and hypersexuality. So somebody who might not, which is also related to the disinhibition, somebody who might not necessarily have been exhibiting a lot of that type of behavior before, particularly in public or not in private, not with the person that they're typically intimate with. Those might be signs and signals that there is something going on. Assessing social status is a key part of doing the medical history, the detailed medical history. And that includes things related to recent changes. So, for example, when somebody recently enters retirement, that's a really significant change in their social status to note, because some of these changes in terms of their levels of depression, their sense of a loss of purpose, their sense of a loss of the social contacts and connections that they might have had in those contexts is really going to be something to pay attention to in understanding what is presenting and whether or not there is a longer history of those behaviors and symptoms presenting. And also living situations. Sometimes as persons age, their living situations change, and these changes to their living situations could also be important to keep in mind in terms of disorientation, etc. Driving and any incidents related to getting lost, accidents, not figuring out what to do and generally feeling a sense of losing their way. Those are also important indicators when you're thinking about assessing social status and recent changes, and assessing risk factors. Risk factors, these comorbidities, we're going to take a look shortly at the Lancet Commission's listing of risk factors over the life course. Comorbidities need to be accounted for. Medications, and particularly polypharmacy. We know this is a real issue in Jamaica and in other Caribbean countries, for example, where there is such a high prevalence of non-communicable diseases, hypertension, cholesterol, diabetes. And so it's important that we try to bridge these silos between these specialties. And this is the great power really that a GP has, and get a sense of what is the lay of the land. What's the whole inventory of medications that this person might be on? Because some of those, as you know, may have contraindications, and that polypharmacy may really be affecting their cognition. Substance use. And then if there's a family history of Alzheimer's disease or any type of related dementia, that's important to capture. Head trauma, we already talked about as well, and hearing impairment. So this is the Lancet Commission's life course model of risk factors for dementias. And the key thing to take away from this image here is that there are risk factors throughout the entire life course. So all of the work that has been happening in Jamaica, that Jamaica really has been leading, from the work of the faculty at the Caribbean Institute for Health Research, Susan Walker and others, for example, on early childhood cognitive stimulation, and Susan Chang and others. All of that's really important, because that education and cognitive stimulation and just being in school, that's actually a protective factor that can help to build cognitive reserve. So finding, when you do that history, when you do that patient history, it's important to understand how much educational exposure do they have? Did they stop school? What is their literacy level? What is their numeracy level? Are there any types of learning differences or intellectual disabilities that may not have presented immediately, but which you might need to capture and think of as a potential factor that could be being construed as cognitive impairment when it might not actually be? And on the other hand, might that lack of education contribute to this later life? We know from the research that, in fact, poor low levels of education in childhood and teenage years is a risk factor for later life dementia progression. In midlife, one of the key risk factors that is not really explored enough, and which again family physicians play an important role in checking, is hearing. So hearing loss, if there is hearing loss, and we've seen in our field work that sometimes people have a lot of impacted wax in their ears, and that is actually presenting may make them present as if they're experiencing cognitive impairment. So it's important to, again, check that. Hearing loss is a risk factor for later life progression of Alzheimer's disease and related dementias. So if you can reduce that risk, for example, encourage persons to wear hearing aids if they do have hearing impairment, that's something to pay attention to. Traumatic brain injury, as we mentioned, we have such a high prevalence of motor vehicle accidents in Jamaica and the broader Caribbean. We have a high prevalence of domestic violence and violent behavior in general. Traumatic brain injury is really something to pay attention to. Hypertension, we've talked about, alcohol consumption and obesity. Those are, again, risk factors for later progression of Alzheimer's disease and related dementias. And then in later life, we know that there is risk as well with smoking, depression, social isolation, physical inactivity, and diabetes. Those are the ones that are at the individual level. And then we have some contextual factors that we're getting more and more research on, air pollution being one of them, and not captured in this Lancet report, but quite likely coming out in the next Lancet Commission, are issues related to sleep and sleep dysregulation, as well as other types of environmental toxins such as mold, and the important role that those play as risk factors in terms of brain pathologies. So the next phase of what it's important to do is to rule out other causes of cognitive impairment. There are some specific tools that you can use to look at delirium, for example. The confusion assessment method is important to utilize these existing standardized tools. Depression, really important to rule out, and there are quick and easy to administer measures for those. Again, investigate whether or not your patient is on any anticholinergics, and those types and any other type of medication that might impact their cognition, and also excessive use of alcohol. And it remains to be said as well, in contexts like ours, excessive use of other substances such as cannabis. There are some tools that have been developed that can help with this as a checklist. This is a tool from one of the partners for the Davos Alzheimer's Collaborative project that we worked with a CCFPJ and other partners on. So this tool, really like a checklist for you to think about, how do you ensure that you're eliminating each of these as potential explanations for what is presenting as cognitive impairment. The next important part of what needs to happen is a cognitive screener. Traditionally, these cognitive screeners are done with paper pencil measures, and a number of you, I'm sure, have gotten your pads from the drug company reps that give you that quick one-page screener. Others that you might use are the MMSE, the MoCA, the MiniCog, the SLUMS. These are all tools that are traditionally used. A number of them are moving to digital platforms. The MoCA in particular is one of them. I've placed there and can put in the chat after a resource for some videos, again, that are online with a company that I did some work with, where I spent some time explaining the similarities and differences between the MMSE and the MoCA, and where and for what they're useful. One is more useful than the other. As I mentioned just now, though, a lot of these tools that have been traditionally paper pencil are moving to digital platforms. And the ways in which that is really going to be useful for us, and that's going to be scaled across countries and across contexts, is going to be very powerful to observe. One of these tools is this Linus Health platform. This is the one that we used recently, but there are a number of them out there that are using either a digital version of an existing measure or creating an entire different digital and in some cases self-administered tool. And in other cases, it must be a health or allied care practitioner administered tool. And with that information can then have a more expedited type of process in dealing with, for example, you as a family physician. So with the Linus Health tool, for example, their core cognitive evaluation, this is a immediate recall test. So 3 words are said, the patient is asked to repeat those words. Then they are tasked with drawing a clock on an iPad using the iPen. And after they've done that, they're tasked with repeating the words that they had said initially. So that's the delayed recall. And after that, there's a life and health questionnaire, which is the subjective part of that particular assessment's cognitive screener. With the Linus platform, what you end up getting, and in many others as well, a lot of these digital platforms are now doing this, you get an immediate scoring and interpretation. With the Linus platform, this is a score of between 0 to 5, and it's scored in a traffic light type of way. So if the patient gets a score that's red, that means that they have screened as cognitively impaired. If they get a score in that yellow or amber range, that means that they're scored as borderline for cognitive impairment. And if they get green, that means that they've screened as cognitively normal. The beauty of platforms like Linus is that it also immediately produces a brain health action plan for the patients, in addition to giving you as a provider clinical insights. And we'll look at some of those in more detail in a bit. The next part of what's really important to do are blood tests for reversible causes of that cognitive impairment, what is presenting as cognitive impairment. This is the typical type of list. You see your complete blood count, your complete, your comprehensive metabolic panel, and other assessments, that investigations that you would typically be asking your patients to do. Neuroimaging, we know that this is not necessarily something that is accessible to the vast majority of our patients, but just for information and for understanding when and for what is really useful, CT scans are really useful to exclude any type of intracranial bleeding, and MRIs are preferred over CT scans in a particular number of cases, especially when there is cortical and hippocampal atrophy, when there is diffuse white matter, ischemic changes, etc. And then there are also PET scans, and PET scans tend to be the gold standard in looking at any particular types of changes and concerns in the brain. And the presence particularly of indicators of two of the main mechanisms that are hypothesized to be leading Alzheimer's disease to progress to dementia. With neuropsychological assessments, this can be particularly comprehensive, and the particular psychologist, neuropsychologist or cognitive psychologist that is conducting these will make an assessment also based on the reports that they've gotten, if there was any neuroimaging done as well, and depending upon what they've gotten as a referral note from you particularly, or from any other referring physician. There's a clinical interview that's conducted where the clinician pays attention to how the individual presents in their attire, in their gait, in their speech, in their sentence construction. Then there is a neuropsychological questionnaire. There's a neurological screener. There are the typical types of intelligence scales and achievement tests and assessments of memory and learning. There is an assessment of executive functioning and other types of measures, including the Stroop color and word test. Other diagnostic tests, cerebrospinal fluid is typically used to identify any type of infectious, inflammatory, or neoplastic processes, and the presence or absence of amyloid or tau protein. And there's more and more work now on blood-based biomarkers. So with these biomarkers and with the particular type of assessment strategy, the modality to assess each of these biomarkers, there are strengths and there are limitations. I've included here the reference for this particular article, and I recommend that you explore this particular article in particular. I'm happy to share the PDFs of these with Dr. Ononuju and the rest of the team for your further distribution and referencing. When we think about what's next, so for example, the physicians are typically really wanting to understand, what do we do? And this is what our patients really want to know too. What do we do if there is, in fact, something happening that is likely Alzheimer's disease? There are no medications right now that are on the market for clinical use. They are being used in research trials right now. But there are no medications that can actually change the course or stop the progression of Alzheimer's disease. Those are called disease-modifying treatments or therapeutics. The medications that are currently on the market that are typically prescribed by our physicians are ones that just treat the symptoms of Alzheimer's disease. So they don't treat the root cause, and they don't slow down how quickly the disease actually progresses. And this is because they're not actually tackling the underlying mechanism. There are multiple hypotheses, and this is really important to understand as well. There are multiple hypotheses about the mechanisms that are undergirding Alzheimer's disease, particularly Alzheimer's disease progressing to dementia. The disease-modifying therapeutics that are being developed now, and we'll see some of them shortly, are really based on one of the exploring monoclonal antibodies for one of those, and that's the amyloid hypothesis. But there's also the tau hypothesis. There's another hypothesis relating to Alzheimer's disease being like a type 3 diabetes, and there are many other types of hypotheses. So as we mentioned just now, the pharmacological management is really focused on reducing the progression of symptoms. There are two types of categories of medications that are typically used for that, as you likely know. One that really prevents the breakdown of acetylcholine, and that's used in mild to moderate stages of the disease. And then memantine, which is used in the moderate to severe stages of Alzheimer's disease, and that regulates glutamate. And so the disease-modifying immunotherapies that we're seeing emerging on the markets now, they target specifically amyloid protein in the brain. There are ones that are FDA approved under accelerated pathways, Aduhelm and lecanemab, which is on the market now as Leqembi. Their clinical endpoints really are aiming to reduce amyloid deposits in the brain and to improve functioning. And they are used particularly for patients with positive amyloid PET scans, with MCI or mild dementia due to Alzheimer's disease. but amyloid-related imaging abnormalities or ARIAs are side effects that patients who are enrolling in these trials really need to be very aware of, because they can in fact lead to death. So how these monoclonal antibodies have been working is that they are really for patients in the early stage of Alzheimer's disease, and they have to have confirmed high levels of amyloid protein in the brain. So those are the only candidates for lecanemab. This is being rolled out in the US in particular and in some European countries, but there's talk as well of it being rolled out in the UK, but there is a whole backlog that needs to be attended to. What this means is that there is dialogue as well about the next generation of clinical pathway for Alzheimer's disease. And that next generation clinical pathway for Alzheimer's disease starts with prevention. And that's really important to keep in mind, particularly as family physicians, because this is a really important role that you play as family physicians, because you must enable preventing the engagement in behaviors. So along the lines of what we're already doing in terms of trying to reduce the risk behaviors for non-communicable disease. And the aim is to expand healthy lifespan. This is the same article that was referenced earlier. And this is for the first part of what is necessary to do. And this is, you promote prevention by exercise, social interaction, diet, medication. If you're looking to detect symptoms, you conduct cognitive screening tests, use blood-based biomarkers and digital technology. There's clinical assessments, biomarker confirmation, treatment initiation, and monitoring treatment response and disease progression. Another aspect of this next generation clinical pathway, care pathway for Alzheimer's disease, really focuses on digital technologies. And these digital technologies can facilitate what's called passive detection, as you see here at the very top, where, for example, your wearables are helping to keep track of information that can lead to, over time, even your voice-activated devices. There are changes that the research is now showing have started to happen at least 20 years before you see a symptom of Alzheimer's disease presenting, that if you're tracking that information, that data, that they can pick up those changes. Just like when you draw the clock, if there are slight tremors as you're drawing the clock on those digital devices, those devices can pick that up. So this is a different and exciting change and development in terms of the clinical care pathway for Alzheimer's disease. And the question that leaves us with is, are health systems actually ready for these new Alzheimer's diagnostics and treatment? And the truth is that what we're seeing from a lot of work that was conducted by RAND and other related investigating companies, think tanks, and academic institutions, is that health systems are definitely not. And we know that particularly in low and middle income countries, we are not ready for these diagnostics and treatments. We see that there's a lot of conversation across health systems globally around this. And as I mentioned just now, the UK is one of them. And so what has been happening is there's a real upsurge now of initiatives to catalyze and scale innovations across the likely trajectory of Alzheimer's disease and related dementia. That includes awareness and activation, includes patient flow, and includes access. So with the DAC project that we collaborated with CCFPJ on, we focused on screening and early detection. This was an initiative that was focusing on the public healthcare system in Brazil, Japan, Mexico, and Scotland, and private healthcare system in the USA, 2 different health systems, and in Jamaica. I've put the reference there, and I can also drop it in the chat after in terms of the case studies. But this was the suggested pathway, the flow for moving from a wellness visit to cognitive assessment, rule outs, blood tests, and then if there was a diagnosis, then deciding on what next steps for the patients. The DAC early detection blueprint was launched a few months ago. And again, we'll put the website in the chat, but each health system or service provider can launch their own early detection program for cognitive impairment. There are modules there to help plan, implement, to monitor and evaluate. And in terms of what we understood from Jamaica and our experience in Jamaica, it's really important to create pathways to get people into the healthcare system. We leveraged early stage health and allied practitioners, and we built relationships as with CCFPJ to raise awareness, and we used our research staff roles flexibly. We are proud to have had this partnership and to continue to have this partnership with CCFPJ. This was a project that was done and involved a lot of different moving parts. So the Brain Health Action Plan, this is personalized guidance for the individual. It also provides, this platform in particular offers a clinical decision support tool, and we're looking forward to working with the practices that participated in this project to roll out these implications even more, particularly using things like the summary cards. We collected over 767 digital cognitive assessments and got over 387 blood panels done and 196 ECGs, and a vast majority of the persons that we saw were in the borderline and cognitively impaired categories. So we're looking forward to sharing more about that with you in a series of webinars that we will be hosting. I'll place the wait list in the chat the information for you to sign up for the wait list for those that webinar series and other training opportunities. But I want to thank you once again for this opportunity to share and to exchange and learn with you. Thank you.
Thank you ever so much, Dr. Gavaya. Really a wealth of information, some very important research that is going on that can be translated into clinical practice. So really very happy to be part of that and to have you present to us today. Again, if there are any questions for Dr. Gavaya, please put them in the Q&A section, and we will get to them after our final presenter. So thanks very much for that, Dr. Gavaya. Now, like a cricket game, you have your opening batsman, your middle order, and now we are coming to our final night watchman, who is going to really sew things up for us. So it gives me great pleasure to introduce our next presenter, Dr. Frank Carl Pensel, who is again a UWI medical graduate, having completed his MBBS at UWI and also did his DM, Doctor of Medicine in the Neurosurgery at UWI, finishing there in 2013. He is currently the Chief Registrar in Neurosurgery at the Cornwall Regional Hospital, and he is also the Consultant Neurosurgeon at Morbay Hospital, Hope Hospital, Hospital in Montego Bay. Over his years of training, he has had a number of experiences in different areas, and he is sharing his knowledge as an associate lecturer with the UWI, teaching neurosurgery to medical students doing their clinical clerkships at Cornwall Regional Hospital, and also being a neuroanatomy lecturer at the UWI Western Campus. he is a co-founder of the Joint Spine Team meeting at the Cornwall Regional Hospital and has done research in a number of areas to do with tumors of the brain. We are very happy to welcome him today as a speaker to speak to us on tumors of the brain. So Dr. Pensel, over to you.
Good night, all. I hope I will just be able to do the topic justice for my esteemed colleagues joining us for this presentation. Tonight we'll be speaking about brain tumors. I've tried to keep it as relatable as possible and to get through some important areas. We're going to be looking at brain and a little bit of the brain anatomy, types of tumors, grades of tumors, discuss a little bit about their risk factors, some signs and symptoms as they relate to the neuroanatomy, how to make the diagnosis, and a brief introduction into the treatment, some of the supportive care and rehabilitation that may go along with the treatment of our brain tumor patients. Now, I understand that this is a very challenging area for both patient and physicians, and even us neurosurgeons sometimes find the case can be a little bit difficult and demanding. So bear with me as we try to make this a more approachable topic. So the brain tumors, of course, we're talking those that are primarily originating within the brain, but we also have to deal with metastatic brain tumors. There's the skull meninges that protect the brain, but of course, this gives us a rigid structure that is enclosed in the brain. And then we have different portions of the brain and the ventricular system, which lies within the brain, to bear in mind. So, tumors may arise from any point within the neuroanatomy, be it outside of the brain from skull or meninges, or within the brain from in the cerebrum, or from within the brainstem, or from the posterior ear of the brain, the cerebellum. A brain tumor is a collection of any mass of abnormal cells within the brain. The skull, of course, which encloses the brain, provides a very rigid encasement for the brain. As such, the Monroe-Kelly doctrine, which we usually discuss as applying in head injuries, also has a place here when it comes on to brain tumor, because within that Monroe-Kelly doctrine framework, 80% of the intracranial pressure is contributed by the brain, and a brain tumor would be considered an abnormal component of brain that would raise the intracranial pressure. Now, how do brain tumors arise? There are multiple theories, and we'll discuss some of this in the risk factors, but they can arise from multiple different types of cells which occur within the brain. Some of my information is a little bit old, taken from when I was presenting as a resident, but looking for newer ones, all I could find was up to 2012, so I just decided to use what I had, which was, of course, sadly, mostly American-based, where there are quite a number of new cases per year, 62,930 within that year that was investigated, 2010, and that was within adult brain tumors, and 4,030 new pediatric tumors, with the large population being Caucasian, more than 70%, then we do expect more white patients to present with brain tumors than Black American. The type of treatment may vary, though, and survival rates will vary based on that demographic. but we won't discuss that significantly here. Children age 0 to 15 and adults within the 5th and 7th decades provide the two main distinct epidemiological peaks of presentation. And the most common brain tumor of primary origin is the meningioma, which is a benign brain tumor in more than 90% of cases, and of course, it accounted for 33.8% of the primary brain tumors. Glioblastomas, or glioblastoma multiforme as previously known, is a malignant tumor which is very common, unfortunately, and has increased from 17% back then to almost 20% currently in terms of adult primary brain tumors. For pediatric tumors, most of them will be in the supratentorial, but of various types. And for the largest single group would be in the posterior fossa, in the cerebellum, accounting for 16% of the brain tumors seen in children. This graphic is one of particular importance that I'd like everyone to focus on. Meningiomas are a large part of what presents to the neurosurgeon. As such, these tumors, if detected early, can be treated early with simple surgical procedures in some cases, sometimes more complex, but them being benign allows for a significant survival rate for patients. Unfortunately, many present very late or in very abnormal, in very poor condition, making it difficult to treat. Early presentation of this type of tumor will allow for better outcome. The next common category of tumors are those that arise within the pituitary area or the cella. And these tumors are treatable with simple surgeries that don't necessarily involve a craniotomy at times, and sometimes don't even require surgery at times. There's a special type of them called prolactinomas, which can be treated by medication. So these two groups are tumors that we would like to be picked up early and managed early by the neurosurgical teams as they exist across the country for improved outcome in our population. The big baddie is the glioblastoma, which accounts, like I said, for almost 20–25% of cases. It is a tumor that unfortunately we have no stop for. We can treat to increase survival, and only in the very rare case where we can get surgical resection of this tumor when it is quite small, do we stand a chance of prolonging patient survival beyond the typical 6 months to 2 years. Types of tumors. WHO started to classify CNS tumors back in 1979 and put them into two main categories: primary brain tumors and secondary brain tumors. That is, those that were metastasized. Of course, primary brain tumors can be divided into both benign and malignant classification as well. The benign tumors are usually able to be treated by surgery or resected completely and rarely ever grow back. Benign tumors have an obvious border when we resect them. They don't spread beyond the brain. They don't invade tissues around them. And though they are not malignant, because of the fact that they're inside a closed space, and because that the fact that they may be adjacent to eloquent brain or very functional brain, they can present with very serious health problems. They can cause weaknesses, presenting similar to strokes. They can compress vital organs or vital tissues, the optic nerve, causing blindness, and in very rare conditions, they may even transform to malignant tumors. Malignant brain tumors, on the other hand, are clearly life-threatening. They grow rapidly, invade into nearby tissue, and the cancer cells may spread to even other parts of the brain and spinal cord. Rarely do they ever spread outside of the brain or primary tissue, but they do spread within the brain. There are 4 main grades of tissue: grade 1 through 4, grade 1 being benign, grade 4 being quite malignant, grade 2 being a little bit abnormal cells, but not yet being malignant, yet being significantly abnormal, and as such are still managed as benign tumors. Grade 3 tumors, however, are malignant tissue, though not as devastatingly rapidly growing as grade 4. This list provides us with the common list of tumors that one will ever encounter in your patients in terms of brain tumors. Gliomas, astrocytomas, and GBMs as a group take up the vast majority, and these arise from astrocytomas, or glial cells within the brain, which are structural brain cells. So similarly, oligodendrogliomas. Ependymomas are derived from the cells which line the ventricles. Medulloblastomas, most commonly seen in children rather than adults, occur in the posterior fossa, and of course, meningiomas may be seen in any age group, but usually your adults. Mature macroadenomas or adenomas can be seen within any age group, usually adulthood, and like I said, these can present with in a significant population of your patients. Some of them can be treated with medication, and the others can be treated with surgery that may not even require going through the cranial vault. Secondary brain tumors are, of course, metastatic brain tumors. Approximately 25% of individuals with systemic cancers will eventually develop a metastasis. 80% are to the cerebrum, 20% to the posterior fossa. A third of brain metastasis usually comes from the lung in patients with lung cancer, and the frequency as is pointed out here in terms of lung being the most common, then breast, then skin, as in melanoma, GI tract, and kidney disease. The frontal lobe, of course, is the most common site, but it's almost the largest area within the brain, and average survival with treatment is approximately 6 months. Hence, and therefore, why doctors or neurosurgeons will tell a patient with metastatic disease most frequently that they have about 6 months to survive. We'll base our assessment on the size of the tumor, whether or not it would be of benefit to resect the tumor to provide a better survival, or if we do not believe that that makes sense, particularly if there's a significant number of metastases, we'll advise otherwise. What are the risk factors that have been included or thought of to be related to brain tumors? Above all, ionizing radiation. We found that there were patients that were exposed to ionizing radiation as children, particularly from way back in the 30s and 40s, when acne was treated by radiotherapy, and then a significant proportion of that population develop gliomas. Yes, acne. High-dose external beam radiotherapy, hence and therefore, can, in the setting of a benign tumor, offer risk or cause risk where it will cause transformation of benign tumors to malignant tumors. Family history, a little bit more difficult to equate, but we have seen in some families an increased number of brain tumors within the family group. Of course, more studies are required. Now, this is probably the most important part of this lecture, the signs and symptoms that one should be looking for your patients. The symptoms of brain tumors really depends upon tumor size, type, and location. Symptoms may be caused when a tumor presses on the nerve or harms different parts of the brain. Above all, the list one should bear in mind headaches, nausea and vomiting, changes in speech, vision or hearing, problems in balance or walking, changes in mood or personality, problems with memory, seizures, muscle jerks or twitching, and numbness or tingling in the arms and legs. Now, of course, these symptoms can be related to multiple other conditions, especially even those that we have discussed before with earlier presentations. But these are our main groups, these are our main symptoms to look out for, that we suggest that they should not be ignored, particularly headaches lasting for a long period of time, particularly worse in the morning, relieved by getting and walking around. So headaches representing in 30% of cases with brain tumors and develops over at least 70% of the cases. It's important to identify the specific nature of the headaches because different headaches have different patterns, especially in patients who have a history of previous headaches. One wants to not just dismiss a complaint of headache when the patient has presented with a history of headaches before. If the headache interrupts sleep or is worse in the awakening and then improves throughout the day, if the headache is elicited by postural changes, coughing or exercise, if it is new in onset or more severe than or different from the previous headaches that they have had, and particularly if you are new onset headaches in a previously asymptomatic patient, one should probably choose to review this patient a little bit quicker, if not, investigate further. Examinations of papilledema, though becoming less rare finding, should never be ignored, should always be borne in mind as a part of the examination process or the findings that one should look for in patients presenting with headache, and especially when they're complaining of nausea and vomiting or have other focal neurological signs. Seizures. Seizure is the presenting symptom in a third of cases and present in 50 to 70% of cases. Now, an adult new onset seizure should never be ignored and has to be evaluated appropriately. It presents in brain tumors about 10 to 20%. And if you have a new onset seizure, it is not, although treatment may be given, it is not the end all and be all. One must evaluate with neuroimaging plus or minus other modalities of seizure evaluation. Seizures produced by gliomas have been looked at, and frontal lobe presents with about 59% of seizures, which causes about 59% of them to have seizures. A parietal lobe tumor, glioma, 40% have seizures. Temporal lobe tumor, with 35% of seizures. And this really depends on location within the temporal lobe. Anterior temporal lobe tips are usually silent for a long time. And occipital lobe, 33% may have seizures. Altered mental status is the initial symptom in 15%, 20% of individuals. And a young patient presenting with mean, just use the term loosely, dementia symptoms should not, particularly if they are less than the typical age group or have no chronic medical illnesses to go along with it, should not just be ignored as new onset dementia or dismissed, but a high index of suspicion should be borne and should be investigated. Papilla edema. The ability to detect a swollen optic disc is a fading skill, and if in doubt, refer to the ophthalmologist. But one should always check for patients with long-standing headaches, abnormal behavior, or new onset deficits. It is more common in children with slow-growing tumors and posterior fossa tumors, of course. Now, let's look at each lobe. The frontal lobe, primary function, you have the motor strip, so motor function, then you have initiation in the premotor area, interpretation of emotion, speech, attention, cognition, emotions, intelligence, judgment, all lie within that area. Hence and therefore, tumors within the frontal lobe can result in abnormalities in these processes: hemiparesis, seizures, aphasias, gait difficulty, disinhibition, irritability, impaired judgment, and lack of initiation. The parietal lobe is responsible for a more complex sensory perception, and the different sides, dominant and the non-dominant parietal lobe, have slightly different functions. So a dominant parietal lobe lesion may present with aphasia and what we call Gertzmann syndrome, where they are having difficulty with the tasks learned during school. Got agraphia, acalculia, inability to write, inability to calculate, and the non-dominant hemisphere would present with that hemi-neglect syndrome. It's not as hard and fast as that, and you may have hemi-neglect from a dominant lobe lesion, but that's the usual rule. So dominant Gertzmann syndromes with acalculia and agraphia, and non-dominant hemi-neglect. Occipital lobe is responsible for processing vision, and the dysfunction in these areas can result in visual agnosia, homonymous hemianopia, where one has lost vision on one side. So a tumor in that area may present with a taximan not being able to see any of the vehicles coming from the left side and simply driving and crashing or hitting down someone because they did not perceive, they cannot process any person coming from that side, and that's usually with a right-sided lesion. If both sides are involved, both occipital lobes are involved, they may present with what we call cortical blindness, where they are not able to truly see because they cannot process what they're seeing, but the eyes and the pathways work up to the cortical, up to the occipital cortex. Antoine syndrome. The temporal lobe is responsible for auditory and limbic processing, that is memory and speech primarily. Now, an anterior lesion may stay silent for a while, as I said before, until it gets larger, but lateral lesions may involve auditory or perceptual changes, and medial lesions may present with cognitive deficit, long-term memory loss, difficulty with learning, and abnormal emotions being demonstrated. The dominant temporal lobe, usually the left side, is usually for speech, as well as writing and comprehension of the language, and the non-dominant maybe in hearing. Bitemporal lesions can present with dementia, abnormal behavior, and in some cases, what we call the Debussy syndrome, where their behavior is so erratic, so wild that they end up on psychiatric wards, restrained. The cerebellum functions for coordination and equilibrium. Common symptoms for adults include headache, nausea, and vomiting in about 40%, and the condition of ataxia, where they have imbalance in 25%. Now, the midline is usually responsible for the trunk or walking, so you have truncular gait ataxia, and the hemispheres more for the limbs, so you can get appendicular ataxia, with upper temporal lower extremity when you have lesions in the lateral cerebral hemispheres. The brainstem is a key area that is of utmost importance, that cannot be overstressed. It is where the basic functions of life exist in terms of your cardiac centers, your respiratory centers. It has reticular formation, which controls consciousness and attention. And then, of course, you have all the tracts that for motor and sensory which pass through, giving the brain the ability to communicate through the body with the rest of the world. As such, brainstem lesions can be quite devastating. They may present initially with diplopia, focal weakness, headaches, vomiting, and I think the most devastating of all of these lesions is to think of is the diffuse intrinsic pontine gliomas that occur in young children between the ages of 4 and 7, where they gradually or suddenly lose the ability to walk, their balance, they develop slurred speech, cast eyes, headaches, and it can be just simply devastating to see these cases, as there's nothing surgical or therapeutic that we have to offer as yet for these children. Pituitary gland. So last year, by far not least, because even though it doesn't account for the vast majority of adult brain tumors, because they do not require ICU as a part of their management in most cases surgically, and there are those cases that just simply require medication, they allow us to, one, treat them both surgically and non-surgically at a far greater rate than other tumors within the cranial cavity because of the chronic lack of ICU space. You know, in Jamaica, we have approximately 10 to 20 available beds, but the WHO standard, I think, is about 5 beds per 100 of the population. And with our current population, we probably need 125 beds. So we're barely reaching the 25, much less the 125 in our population. So a lot of brain tumors go unoperated on or get bumped frequently. The current problem that I saw as a resident, current problem I saw as a consultant, where we'd had to be canceling these cases simply because there was no ICU in order to treat these patients. But pituitary gland tumors don't necessarily need an ICU because we can go transnasally and resect most of these tumors. The pituitary gland is, of course, the master gland. It produces hormones from both an anterior and posterior portion of the gland. There's simple mnemonic GP flat, growth hormone and prolactin from the posterior gland, and flat FSH, LH, ACTH, and TSH, which is the follicle-stimulating hormone, luteinizing hormone, adrenocorticotrophic hormone, and thyroid-stimulating hormone from the anterior portion of the gland. And of course, there are non-active cells that lie and make up the structure of the body of the gland. But if there's a tumor within the gland, they can compress normal functioning cells and result in hypofunction of the gland, as well as right above the pituitary gland lies the optic chiasm, where vision passes through to cross from left to right and right to left, as appropriate in order to for processing in the occipital lobe, keeping the left side of vision on the right side of the brain and right side of vision on the left side of the brain. But if there is a large tumor, it can go and compress the optic nerve and even get large enough to compress enough of the optic apparatus that can lead to blindness. So an important part of it is not only to preserve the function of the pituitary gland, but also to save vision. So this is a quick summary of what we've just discussed in terms of where portion of the brain and what lesions they will, or what symptoms they will and signs they will present with, and will be a part of the presentation. Of course, that is recorded, so one will have this that can easily be printed and placed in offices to help guide. Now, how do we make the diagnosis with that information? A clinical diagnosis consists, of course, of information gathered from a history, as well as a neurological examination that is done, and of course, a high index of suspicion. Now, the medical history and the neurological examination include testing of reflexes, visual, cranial nerves, upper and lower limb, motor, sensory, and balance, as well as looking at the back of the eyes for papilledema, are all expected to be standard parts of the evaluation for a patient where one suspects a brain tumor. Of course, in this modern era, we have CT scan and MRI, but it must be remembered and pointed out that CT and MRI, as valuable as they have become, they only form 5 to 10% of our diagnostic tool. Our primary diagnostic tool should be our history and examination, making a diagnosis from there and confirming it with a CT and MRI, and of course doing other investigations as necessary. Now we'll scroll through the static imaging such as CT scan, which is quick, cheap, runs approximately 20 to 30,000 depending on the center where one does it, but it has ionizing radiation. It does not image the posterior fossa well or any closed brain spaces, skull spaces as well. The CT, for the most part, has become superseded by the MRI, which gives multiplanar viewing and is the procedure of choice. It does not use ionizing radiation, but a magnetic field. And the drawback is it takes a while to get. It is expensive, averaging anywhere between 60 and 80,000, or 50 and 80,000, depending on where it's ordered. And not everyone tolerates that MRI as easy as a CT scan, because most of the MRIs available in Jamaica are closed spaces. Dynamic imaging such as PET scans now coming into play within our community because cyclotron has been added to one of our private centers, maybe added at university soon. Will also help with the diagnostic criteria. They help by doing metabolic testing of tumors and help to give us some information as to the activity of tumors and whether or not these are malignant or benign. But again, too new and modality to be caught upon whether or not we're investigating, but it's more a good follow-up tool to use after resection. Single photon emission, CT scan, SPECT scan, also not widely available as yet, but would be valuable too. I think it also has some role in early stroke evaluation. MRI spectroscopy, of course. But for the most part, once one has the thought of having a brain tumor, be it wherever one thinks it superior, then the cerebellum or supratentorial or infratentorial, a CT or MRI should be the first investigative choice. But MRI, if the patient can afford, if time allows it, then that saves them the cost of doing 2 tests. Sometimes we have to do both because sometimes we have to marry the imaging in terms of what we call computed integration of the imaging in order to best guide resection, frequently used in our pituitary tumor resections, where we marry the bony image with the brain MRI in order to best guide our path and surgery during operations. But for the most part, the other aspects, PET and SPECT, would be added later on into our armamentarium. What do we do once we suspect that there is a brain tumor? Really depends on where it is, the size, and the symptoms that are having that they are causing, and the complexity of the case. Some tumors, we can do a complete excision or biopsy at the get-go. Some tumors, we can only get a small bit of tissue to find out exactly what is going on. And this must be judged based on the patient's presentation. Subject an elderly patient with a clear case of glioblastoma where we can see tumor invading from brain into the corpus callosum to say that we're going to do a large resection of the brain tumor would be a little bit gung-ho and probably inappropriate medicine. But and a simple biopsy to confirm the diagnosis and to plan the rest of the treatment in terms of availability of temozolomide, whether or not they meet the Karnofsky score that should allow for further treatment, has to be borne in mind when we decide to treat patients. Of course, other laboratory tests that come into play, perimetry. For all of our patients with pituitary adenomas, we want to test, make sure that their visual fields are intact, so we send them for Goldman perimetry. An EEG for patients who are particularly presented with seizures. Lumbar punctures may come into play for some cases, but it's not usually indicated, particularly for lateralizing brain tumors, but may come into play for select cases where we want to, particularly pediatric tumors, midline tumors, we want to rule out drop metastasis, or if the tumors have started to spread into the spinal canal. But again, those are specialist tests done by the specialist at the time they're evaluating the patient. Audiometry, of course, for patients with CP angle tumor, that's tumors related to the brainstem and the cerebellum, and of course, endocrine testing if the patient presents with a pituitary gland. The most important test is the prolactinoma, is the prolactin test. If it is deemed to be a prolactinoma, and note, not all elevated prolactin levels make it a prolactinoma. It is really based on a statistical probability that if when tested, the value, and this is the metrics scale testing, if the value is 200 nanograms per deciliter or more, then it's likely, it is diagnostically diagnosed as a prolactinoma. There's a range of 0 to 19 as normal, and as much as, we usually see it five times, which brings that up to the 200, up to 100, sorry, but it could be a little bit higher, but up to 5 times can be what we call a stalk effect, where it's a benign tumor or a non-functional tumor within the pituitary gland that is abnormally deviating the pituitary stalk that causes that high prolactin level, but it does not make it a true prolactinoma, and as such would still most likely be treated by a surgical resection. Again, this is information that will be deemed, that will best be managed by the neurosurgeon at the time, but we would love that if once one suspects a pituitary tumor, that our prolactin level is garnered immediately. I won't go much into treatment because the important part of it is to get the patients in to see the neurosurgeon as early as possible so that we can make a real difference, particularly for those benign tumors. I've mentioned the Karnofsky score before, and it is based on this, how well a patient is doing, usually 70 or above. That one will determine how aggressive one is in treating the patient. There are multiple modalities of treatment, be they traditional surgery, chemotherapy, radiation therapy, or stereotactic radiosurgery. But as mentioned before, traditional surgery, the craniotomy and the resection, there has been a long-standing difficulty in our population due to the lack of ICU space availability. Usually really depends on the histological type that we're dealing with, the location, and the tumor size that makes sure that. And once proven to be malignant, there's chemotherapy that's available for varying tumors that will be provided by, and that will be guided by the biopsy. Fortunately, one doesn't get chemotherapeutic agents unless one has a biopsy that proves the type of tumor. And that remains true for the most part. So early diagnosis, early biopsy, early recognition can help prolong the livelihood and functionality of our patients. Radiation therapy is a good adjunct, and sometimes if we have good conformational radiotherapy or stereotactic radiosurgery, not yet available within the nation, we do have the equipment, but we don't have the software that goes along with the equipment that was purchased through the Chase Foundation and placed in Montego Bay and Kingston. The software itself doesn't allow for stereotactic radiosurgery. The good conformational radiotherapy is available and helps to manage some of our cases. I will leave the presentation at that. Thank you all very much for paying attention to me while I rambled on. Thank you.
Thank you very much, Dr. Pencil, for guiding us through what we as family physicians can do to make sure that we diagnose, refer in a timely manner so that you, the neurosurgeon, can have a real chance of making a difference in these patients' lives. So thank you very much for that. I know Dr. Gale and Dr. Govia have been answering some of the questions that were placed in the question and answer. I know there are some for Dr. Pencil as well. Sam, you want to guide us as to how we go through the question and answer?
Oh, well, sure. We can just go ahead and read what we're seeing.
All right. Okay. Let me look at some of the things that have been answered and just let's go through them quickly. The question was asked, would secondary smoke exposure be considered a trigger for multiple sclerosis development? And the short answer to that was yes, that passive smoke is associated with an increased risk of MS for women and children in particular.
Doc, let me try and see if I can help here. Let's see if we can answer one of the questions that's not been answered yet. Let's see if we can get Dr. Gale on. So the first one is about MS. And the question is, what is available locally to manage MS?
Okay.
All right. And since I'm about 2 weeks into my journey in Jamaica, that's a very good question. The last time I checked, interferons were readily available. Rituximab, readily available. Some of the more powerful agents like natalizumab, up to about 2 years ago, I did not find that readily available in Jamaica. I have not checked since I've been home over the last 2 weeks. In term, someone else had answered? No?
That was a
Okay.
fantastic answer. Thank you very much.
Oh, no. I was just wondering if someone else had answered. Some of the oral agents like Tecfidera, up to about 2 years ago, was not available. I'm not sure if it is currently available in Jamaica. If anyone else on the panel knows what's been happening over the last 2 years, be sure to chime in at this point.
Thank you, Dr. Gale, for that. Mr. Heron, you want to go? Are there others that are not? The persons who are in the room, the participants can go ahead and look at those that are where the answers have been typed in, and we will try and deal with the ones that are not typed in. Go ahead, Mr. Heron.
Thank you so much, Doug. So, Phaedra Kepler is asking, Dr. Gale, what is your suggested approach to a patient who presents with imaging showing evidence of small vessel disease?
Oh, okay. So small vessel disease, as we had briefly touched, is now seen as a disease entity that can go in 2 directions. And one is that it is a precursor for ischemic complications, which includes vascular dementia, mild cognitive impairment, and even small vessel strokes, such as lacunes. But there is another paradigm which actually sees small vessel disease as a subset of amyloid processes within the brain, so cerebral amyloid angiopathy. And in those instances, you can actually have microbleeds. And so no longer are we looking at small vessel disease as something benign. And so when we see it, we first screen the patients for hypertension, diabetes, dyslipidemia. We actually do a neurocognitive assessment to see whether or not they're having any decline in their higher mental function. And if we see any neurologic examination, any asymmetry that could suggest that they may have had an insult, whether a lacoon or a microbleed, then we actually should characterize that in details using an MRI of the brain, because that can have some implication as to the role of things like aspirin. Because in microbleeds, if you have many, these individuals are at a higher risk of bleeding if you have them on antiplatelets.
Thank you, Dr. Gale. Dr. Kovaya had answered hers in typing, but I just asked her to there is one question that was asked. Is there a relationship between high-profile executive job and brain disease? Particularly, they're talking about Alzheimer's later in life. I saw that what you typed in, Dr. Kovaya, but you might want to say a few words to that live.
Sure. Thanks, Dr. Standard Golson. Yeah, so as I indicated in the chat there is research that suggests that the brain's development and functioning is actually associated with building cognitive reserve in those that have high mentally and cognitively stimulating jobs. The research suggests that the longer time that people are actually engaged in that type of job situation, the more those changes and building up of that cognitive reserve happens. There's an interesting association, though, for those that are involved in physically demanding jobs as well, because the physically demanding jobs actually are related to another risk factor, which is the lack of physical activity. So for people who are not exercising regularly, for people who are overweight, not having a physically demanding job, for example, a sedentary type of job, most academics, most people who are in offices and not having to get up and move around a lot, those persons are more at risk. So it's not necessarily a very clear-cut association, so that if you have a job that sees you behind an office desk all the time, that means that you're actually not going to be at risk. It's really a complexity of factors. But in the short of it is that for those that are involved in cognitively demanding jobs, there is a strong association with building of cognitive reserve, with the caveats that there needs to be attention to the other risk factors as well.
Thank you very much for that. Please refer to the typed in answers for the other ones. And I'll just ask Dr. Pencil if you would make a comment on whether there has been an increase in brain tumors in the Caribbean over recent years. Dr. Pencil?
Yes, here. What we do believe, first of all, was that for a long time, the Caribbean had very poor imaging centers available to imaging, availability of evaluating these patients, and a lot of stigmata in terms of phobia and other less educated guesses as to why patients may not have had intracranial pathology. We believe now that there has been an uptick in both education as well as diagnostic services. So we can't truly prove that there's been an increase in the incidence or the pathology that may have existed from before. What we do know is that there's increased detection of intracranial pathology, and with improved availability, we expect to improve our practice and improve our ability to treat the population. But to say that there is more cases occurring in the Caribbean, hard to say as yet. And sadly, we don't do enough of our own statistics here. Hopefully, we'll get more.
We'll get there. Thanks for that. Mr. Heron, do we have the ability for people to raise their hands? We could take.
Yes, we do, Doc. We can take a vocal question. Dr. Paulie Williams can raise her hand immediately.
Yes, we have time for maybe 3 questions. So with Dr.
Sure.
Paulie Williams Green, you can open her mic for her. Go ahead.
Sure. Go ahead.
Thank you.
Go ahead, Doc.
I was trying to write my question. It's the doctor. First of all, congratulations on a fabulous seminar.
Yeah.
Really great. Dr. Pencil, I noticed in one of your diagrams, you mentioned intentional tremor with regards to the cerebellum. Were you suggesting that patients diagnosed with intentional tremor should probably be investigated for tumors?
I do believe that intentional tremors should all be evaluated by imaging. Because we have to look at the cerebellum first. Remember, Parkinson's is either diagnosed as a rested tremor, but intentional tremors can be caused by either drugs or cerebellar atrophy or a lesion within the cerebellum. Of course, it can be the the exaggerated physiological tremor that we can be seen commonly, but that patient wouldn't necessarily always be in that high risk, in that greater risk, that 5th to 7th decade of life or early. So intentional tremors, I believe, should be imaged because they are at risk of having a cerebellar pathology, and the imaging will only help to guide or help our management. of these patients. It is the resting tremor which goes straight to the Parkinson's disease, which doesn't necessarily require any imaging.
Thank you. A very important distinction there. Thanks very much for that. I take two more questions. If there are any, please put up the hands and we would entertain them for any of our presenters, any of the three presenters.
Thank you. I'm not seeing any hands up yet. So in the meantime, while persons get ready for their questions, I do see a new one here by Richard Van Turen. It's a two-part question. Great talks, great speakers, informative and fabulous sides. This question is for Dr. Gale. You mentioned that you have experience with 4 categories of MS. Do you have experience with 1, clinically isolated syndrome where one can get a single episode of neurological symptoms, or 2, benign MS with almost complete remission between relapses and little physical disability over time? Dr. Gale, over to you.
And it's actually typed in if you want to look at it.
Oh no, I'm quicker at speaking than typing.
No, I mean if you want to see what was typed in, not that you type in.
Okay, so great question. So the concept of the clinically isolated syndrome speaks to the presence of, let's say, optic neuritis with a pristine brain on MRI and a pristine spinal cord, pristine neurologic exam. And the conundrum was, what should we do with these individuals? Should they be observed or should they be started on disease-modifying agents? And after much deliberation, it was actually concluded that commencing disease-modifying agents actually decreased the occurrence of the next relapse. And overall decreased the progression in their disability scores over time. This has shifted the whole landscape of multiple sclerosis from a watch and wait approach to more of an aggressive intervention approach where the expectation is no disease detected. Right? And so that's a very important mind shift that our family physicians and our general practitioners should remember. The second question is, yes, I've actually come across individuals who have seemingly gone into what we would almost describe as a spontaneous remission. That subset of individuals have been studied and various postulations have popped up as to why this has been. And pretty much, you know, to my recollection, there has been no unifying etiology or characteristic that has predisposed one group versus the other, except to say the usual environmental characteristics that predispose individuals to multiple sclerosis in the first place. So we have more of a positive predictive factors that put you at risk of multiple sclerosis versus factors that prevent you from progressing. I hope you understand that subtlety.
Thank you very much for that, Dr. Gale. I see another one was has been typed in. This will be our last one. It's a case. It is an 80-year-old female with severe atrophy, widespread, and having small vessel disease with memory impairment. Her cholesterol is in control. Her hypertension is now controlled, and no diabetes. Question: what would cause her memory impairment? I don't know if Dr. Gale, you want to?
Or dementia specialist, I will defer to her.
Dr. Guraya?
I'm quite good with deferring to you with this one, Dr. Gale. I mean, when I see something like that, because her comorbidities are under control and her cardiometabolic factors seem to be being managed, there is the potential that this is a Alzheimer's disease type of progression. And so that's what I would be led to conclude and to want to do some further investigations on. I don't know, Dr. Gale, what your thoughts are.
Yeah, I would agree with you. I would think Alzheimer's with the small vessel disease perhaps being a cerebral amyloid angiopathy spin-off, because CAA can look like small vessel disease. I have rarely seen small vessel disease appearing MRIs that are actually leukodystrophies. Now we're getting into some details, guys. You know, I love this bunch. You have a very good bunch. You can rarely have a pattern that looks like small vessel disease, but it's actually white matter disease because of other causes. And those other causes can be vitamin B12 deficiencies, leukodystrophies, other rarer causes, and some rare genetic conditions which typically would have presented long before the age of 80. Things like CADASIL being one of them that can cause dementia and white matter disease. But great questions, guys.
And Dr. Pencil also put in his word here where he says she already has severe atrophy with widespread small vessel disease. The setup for dementia is already there. So I think all three of you are agreeing. Final question, can we rule out MS if MRI of brain and spinal cord are normal? Dr. Gale?
Oh, coming back. All right, so can we rule out MS? I would have to say that the simple answer to that is no, we can't. Because it depends, again, it's a spin-off of the previous question, because you can have a clinically isolated syndrome where the patient presents with the typical clinical syndrome of an optic neuritis, but their brain is pristine and the spine is pristine, right? So that would be considered a clinically isolated syndrome. And then you can actually have some of those invisible symptoms that may predate the actual accumulation of significant plaques within the brain, especially the fatigue. Yes. The fatigue is one that can be around for a long time before the actual diagnosis is made.
Thank you all so much. The question is in the chat. Will the slides be shared? Once our presenters agree and share the presentation with us, I'm sure that the college will find a way to disseminate. So I will ask at this time, we want the formal vote of thanks. I'm going to ask our president of the CCFP Jamaica chapter, Dr. Ananuja, just to do the honors with the vote of thanks.
Good evening, everyone. Thank you, Dr. Golson. I think you've done a wonderful job. On behalf of the Caribbean College of Family Physicians, Jamaican chapter, I am here today at this moment with a heart brimming with gratitude. We have just concluded the first session of our much anticipated Neurology Symposium, delving into the intricate theme, varying phases of neurological disorders in primary care. I hope that if others agree with me, that we have really delved into the 3 topics that we started. We started with these topics because we wanted the ones that we think more students or more doctors will attend for Sunday. But with these 3 that we've started, I think I am quite pleased on behalf of many others that they were all very well presented. And this evening has been a testament to the power of collaboration, expertise, and commitment to advancing medical knowledge. First and foremost, I extend my sincerest thanks to our esteemed presenters, Dr. Francine Gale, Dr. Esther Gobaya, and Dr. George Penkel. You all did a great job. I wouldn't say this is better or this is not so much better, but every subject was well explored, and I imagine that all those who were listening certainly would have learned something new. And at first, I was thinking that we will not like the neurosurgical topic, but as we continued, I realized that not everybody, but most people liked it. So I think we met our objective right there. Your dedication to our moderator, who skillfully steered the discussions and ensured the smooth flow of the symposium, we owe you a debt of gratitude. Your guidance has been instrumental in maximizing the engagement and learning experience for all attendees. I extend my heartfelt thank you to each attendee present here today. Your active participation and eagerness to learn are the driving forces behind the success of the symposium. Your commitment to advancing medical knowledge and improving patient care was truly, and it is truly inspiring. Behind the scene, a team of dedicated individuals worked tirelessly to ensure this seamless organization and execution of this event. I extend my deepest appreciation to the administrative team led by Lynn Thompson-Hyatt, whose meticulous planning and attention to details have made this symposium possible. Likewise, I express gratitude to our IT support personnel, Samuel Heron, who has provided technical expertise and his technical expertise has been invaluable in facilitating the smooth running of this virtual symposium. No event of this magnitude can thrive without the generous support of sponsors. Therefore, I extend warm thanks to Abbott Nutritionals, Indoors, and Health 2000 Canada for their sponsorship and unwavering commitment to advancing medical education and research. As we conclude this session tonight, I would like to remind all attendees to join us again on Sunday, March 24, 2024, that is this Sunday at 8 a.m. for the continuation of this symposium. The topics we have there, I assume, are our day-to-day they are more common than what we did today. The reason why I place these topics here is because I want some patients, like particularly the multiple sclerosis, as you notice, can easily be missed if one is not paying particular or pertinent attention. So for those who have difficulty in picking up them up, because they are you usually find these patients around the ages of 20 and 40. And if you are not paying attention, they could easily be missed. I thought that those who felt that they needed extra attention, how to pick up these patients, should at least make the sacrifice to come to this evening as symposium, as to the Sunday symposium has to do with a more common pathology like fits, epilepsy, stroke, headaches, things that the patient come to you, they complain, or either they are moving or they stop moving, and you have something to say, well, this could be this and this. Even if you are not sure, it's easier for you to pick up the patient if you can manage it with fair. So we are hoping that those patients, those doctors, just to expand your knowledge a little more than what we are having, we all benefit from that. So I'm inviting all our doctors and healthcare professionals to try and attend. That in closing, let us carry forward the spirit of collaboration, learning, and dedication that have defined this symposium. May we continue to work hard and work hand in hand to enhance patient care and contribute to the advancement of medical science. I'm started with our presenters, and before I conclude, I must thank all three of you because you were invited late, and I am grateful that you did not disappoint us. Thank you very much on behalf of all of us.
Thank you very much, Dr. Seni, and a very, very good night to you all. Look forward to seeing you all and more on Sunday.
Yeah.
Have a very good night.
Thank you.
Good night, everyone. Night, night. See you on Sunday.
Yeah.
Bye. Thank you.